Good morning. Thanks so much for the introduction. Thank you so much for that presentation, Nancy. What I am going to talk about hopefully builds nicely upon it, because I have the great pleasure of talking to you all about the law, or the system of obstacles and burdens, as some of you may see it. Unfortunately, if we're going to talk about meaningful choice, if we're going to talk about privacy protections, and if we're going to talk about data sharing, you can't really have an effective policy discussion about these issues until you first understand what is not possible legally. And so I will do my best, despite some fairly dense slides, to go not quickly in my speaking, but briefly at a high level through these first slides so that I can at least keep you somewhat awake. First, a little bit about the Health Privacy Project at the Center for Democracy and Technology. The project is premised upon the notion that I'm sure we would all agree with, that health IT and the exchange of electronic health information are really the drivers and engines of health reform with the greatest potential to improve health. And certainly in this new electronic health environment, some progress has been made to update and resolve some of the privacy and security challenges that arose when our system kind of got turned on its head and became digitized. But as everyone is far too familiar with, a number of questions and challenges and implementation issues still exist, notwithstanding some really solid and important and meaningful efforts on the part of HHS and CMS to update the HIPAA medical privacy rule and others to better fit this new environment. This last bullet is to hopefully toot our own horn a little bit in saying that the solutions that we advocate are really those that are practical. Too often, I think privacy advocates are seen as hysterical. Consumer advocates are seen as hysterical. And we really try to work with people like you who are like-minded to find workable solutions to not only keep privacy and security central and paramount, but to get data liquid and freely flowing so that it can be leveraged for all of the purposes that it needs to be. I think these first couple of bullets about what a learning healthcare system is are written by people in this room. I certainly know this first one comes from Nancy. There are a lot of different ways to talk about a learning healthcare system and to define it, but for my purposes and my work, it's the focus is really this need to safely and securely leverage clinical data for purposes that are beyond treatment and payment, and that a learning healthcare system is not going to be possible unless we find ways to do this. Okay, a little bit about HIPAA. Big question when it comes to research is, first of all, does HIPAA, again, this is the medical privacy law, apply, the federal medical privacy law? And these bullets are about the identifiability of the data, because if data is de-identified, HIPAA does not apply. There are numerous and technical ways to de-identify your data. There's legal standards, there are methodologies to do it. And limited data sets are familiar to all of you in the research community because they're a close cousin to de-identified data. They involve some removal of categories of information, and they're permitted for research. Data holders are required to execute data use agreements to use limited data sets or information in limited data sets, but individual consent is typically not required, which makes that quite attractive. Again, the reason that this is important is because, as many of you know, in order for information that is patient identifiable to be used for research purposes, you have to obtain patient authorization. Authorization is the legal term. Consent is more typically the policy term, and we'll talk a little bit about that. But with a few exceptions, a privacy board waiver or an IRB waiver or some exceptions found in the law, this individual authorization is necessary. Now, that is not easy to obtain and often seen as incredibly onerous, so it makes perfect sense that research on data that qualified as de-identified is largely not regulated and therefore enormously attractive to those who are engaging in research. Unfortunately, it's not just HIPAA that we all have to worry about. I'm not going to go through all these, but there are numerous other state and local laws and regulations that can apply depending on the nature of the data, depending on the nature of the study. Everything from the Common Rule, which I'll talk about briefly on the next slide because it governs federally funded research, to state laws, to health information exchange policies, to grant conditions, and sometimes even international laws. The common rule, the big research rule for federally funded research on identifiable data, it's not that it's not worth talking about it, but as some of you may know, about 18 months ago, what's called advanced notice of proposed rulemaking, kind of a early heads up that, hey, we're going to do some regulating on this subject, was released that proposed some fairly significant changes. And the good news is that they all seem to be designed to bring it in line with the HIPAA law. There's some gaps and there's some confusion, and there are a number of headaches caused by the relationship between HIPAA and the common rule. And we're hoping that once we get a little bit farther down the regulatory process with this rule, we'll feel a little bit better. As we heard a little bit, and I'll just say more specifically, there are some really common and legitimate criticisms of this legal framework that we have right now. And as you could argue from my presentation, there's a disproportionate focus on whether or not the data is identifiable and whether or not patient consent is required. And having sort of laser beam focus on, is the data stripped of these 18 or 16 or however many identifiers, and do we need to obtain patient authorization or consent, ignores a number of other valid and hugely important privacy protections that are available to us. And unsurprisingly, there's a real push or sort of tend to be conservative on the part of researchers in their interpretation of these rules and requirements for obvious reasons. You don't want to get in trouble, and it's better to be safe than sorry. Unfortunately, that ends up causing or creating obstacles and barriers to research and to data sharing more broadly that may not actually exist or should not exist. So, what would we like instead? A comprehensive privacy and security framework is desperately needed, not just for medical information, but really for consumer individual information writ large. Until we have that, it's probably not going to be this open, safe, secure facilitating of health IT and health information exchange that we would like. There should be less focus on consent and more focus on the rest of the so-called fair information practice principles. Sometimes they're FIPs, sometimes they're FIPs. And I've got a slide about those in a couple minutes, or a couple of slides, but the notion is that let's broaden our focus and think about all the different tools in our arsenal and try to get away from this headache of consent. And central to this, and fitting in with this broader theme of this whole meeting of consumer and patient engagement, is that any privacy and security framework has got to incorporate notions of consumer and patient expectations. This idea of context when you're deciding which of the tools to pull out from your toolbox to protect privacy is important, because in different contexts, patients expect different things. And what you want is for no one to ever feel surprised or shocked or upset about a particular use of their health information. But you also don't want to assume that that a person is going to be shocked or upset or unwilling to share health information in a particular context. And you don't know that until you've had full and open transparency and engagement. So if we could get all of these, you really have the basis for meaningful choice. Meaningful choice, and this does not just apply to research, but really consumer choice for use and exchange of health information in general, centers around a number of principles, the sort of most important ones I've highlighted here. You have to be able to make the choice in advance. You have to be free to make the choice. You can't feel like if you say no to something that something is going to be withheld from you, for example, medical treatment. And there needs to be absolutely full transparency and education about what that choice entails. Without that, it's not meaningful. So this notion of opt-in or opt-out and the endless hours of discussion and debate that yours truly and many probably of you have sat in about what is it going to be opt-in or opt-out shouldn't matter as much if the choice, regardless of the system for giving it, is meaningful. These fair information practice principles, this list that I've given was developed or articulated by the Markle Connecting for Health initiative, but they can be found in a number of different articulations: the Federal Trade Commission, the Department of Health and Human Services, the Office of the National Coordinator for Health IT has its own set, but they have sort of similar themes that are the most relevant. And I won't read them all out for you, but you can see that this idea of choice is but one. The idea that you should be able to consent to the use and exchange of your health information is certainly important, but so too is openness and transparency, understanding the purpose, feeling that the very least of your data that is necessary is going to be used, that you have some ability to participate and control, that the data is accurate, that it's safe, and that there's some accountability and oversight for the use of your information. My next couple of slides are on ways to structure research networks to achieve this, distributed networks versus centralized networks, but I am running out of time, and I think that may be left best to more specific conversations later offline if you'd like. I think ending on the fair information practices is most relevant to this presentation, so I look forward to the discussion afterwards. Thank you.